First of all, thank you so much for a very extensive introduction of my CV. I appreciate that usually, but I thank you so much. It is truly a pleasure to be here to address you today. And, you know, in this kind of meetings, it's a learning process. So I'm here to learn, and probably you also learn from what you've been doing. So kind of, if you like, learning, a process from everybody. My name is Charles. I've already been introduced, and I'm based in Amsterdam Medical Center. And today my talk is going to basically touch on non-communicable diseases. In other words, chronic diseases, as the people say. And I will be using the African migrants as the focus. But I will try and also look at it from a European perspective and other minority populations as well. Okay, so this one here. Oh, I can do this. Yep, perfect. Thank you so much. Yeah. Okay.
Sorry, one moment.
Yeah. Yeah. Then is it working now? Yep.
No, ya está. Mejor.
Okay.
Okay.
Yep, it's working now. Okay. Thank you so much. Yeah. Okay. 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 This one? Yep. Okay. Yep, that's perfect. Thank you so much and sorry for this. What I'm going to try basically to capture this morning is to basically give an idea about the global burden of NCDs, and then I'll talk a little bit more about the disparities, whereby then I'll touch on the ethnic inequalities, in other words, the health of the migrant populations, and I will discuss a little bit about the underlying factors and some of the challenges. And last but not least, I will try and basically introduce the RODAM project, which I'm currently leading, and sort of trying to come up with a different concept, how you look at minority populations. In other words, how can we take advantage of the health of the migrant population, also to help their own countries where they come from. First of all, particularly those people that are working on chronic, non-communicable diseases. If you look at these figures, there has been a huge improvement for the last couple of decades. And I think we need to basically congratulate people working on communicable diseases of making such a huge impact on the global arena. And if you look at these, basically, if you look at the maternal mortality, you see a downward trend. The same thing of infant mortality. You see clearly in all parts of the world, you're beginning to see improvement. Nevertheless, you also see a huge disparities across different parts of the world. If you look at the African today, in 2012, you're talking about 63 per 1,000 live births, compared to Europe, just about 10. You see a huge disparities across the globe. For me as a person and also as an epidemiologist, one of the things that actually strikes me very much is when you start to look at life expectancy. As you know, life expectancy is one of the important markers of development. And one of the things that strikes me is that if one lives in Europe, if you are a man, your chances of living is nearly 20 years more than someone living in Africa. I think that's quite striking. And that leads to the question, why is such huge inequalities? And that speaks for itself. And also, even if one lives to Africa itself, again, here you see a huge disparities across the African region, depending upon which country one lives. Again, inequalities clearly speaks for itself when one starts to look at these figures. And then what's also making us ask, what's actually leading to such a huge inequalities across both the world and also within Africa. Of course, there are a lot of many challenges, there's no doubt. And I think it'd be a shame if you think it isn't, because basically, if you look at communicable diseases, HIV, AIDS is all over the place. It's a huge problem. But there is also a growing threat of NCDs. And this is what others refer to as double burden of disease. And what you are seeing is that actually within the same country, you can see one part of the country where people are actually malnourished, and the other part where people are actually overnourished. Again, here reflecting on the inequalities. Again, when I talk about NCDs, I think I'm going to touch on this, CVDs, it's a cardiovascular disease, cancers, chronic, but mainly I'll be touching on cardiovascular diseases because it's very much of a problem which also driving many part of the problem, and diabetes. And of course, we know that before we used to think that, chronic disease used to be the rich man's disease. But it's no more, because basically most of these chronic diseases, about 80% of them, actually happen in lower middle-income countries. We also know that these conditions, if you live in Europe, it affects you when you are older. In lower middle-income countries, actually affect people when they are younger. And that has a huge consequences on the economic development of these countries. And it's also basically putting major families into poverty. And I can use an example, for instance. If you live in a very poor household in Africa elsewhere, and if you have a diabetes, the money that you actually use for the health care for the whole year is much more than the entire income coming into the family. So you can immediately see the effect of that on the families. So here, human face is clearly in it. Basically, these are the distribution. I think probably many of you have seen this before. Basically, if you look at the global distribution you see that, again, here, NCDs clearly taking a large chunk of that. And if you look at NCDs, again, cardiovascular disease is nearly half of this problem. And, of course, diabetes and others, which I'm going to touch on. And it's basically cut across all parts of the world. I mean, except for Africa, which infectious diseases or communicable disease is still the major part. But all the projection is that this is going to change very soon. Across all the globe, you clearly see that non-communicable or chronic diseases is actually taking over. And I show this picture because this picture actually, here, the interesting thing is about the arrows, what the arrows is actually doing. These are the projections from World Health Statistics. And basically what you are seeing is that all the arrows coming here are actually communicable diseases. And those going up here are chronic diseases. In other words, communicable diseases, we are really making progress. But for chronic diseases, we haven't. And there is a need to correct that. And indeed, this is not. This is basically cardiovascular mortality, in other words, across world region. Again, this is from WHO. And what you are seeing that if you look at the poorer countries, this is men and this is women. So the more red it gets, the higher it is. So basically what you're seeing is that all the red is actually scattered across poorer part of the world compared to, say, richer part of Europe and then North America. So this figure clearly shows that it is a problem for the poor. Now, in terms of risk factors, clearly behavior part play a very important role. And what we know is that the tobacco use, of course, is very important. What you also know that the tobacco companies are now being very smart, because if you live in Europe and America, the rules are very strict. But if you live in the poorer communities or poorer countries, there isn't that much of a policy strict. So they are taking advantage of that. Of course, physical inactivity, poor diet, and harmful use of alcohol. And then the metabolic risk. And particularly for the African population, hypertension is a major, major issue here, which I have done a lot of work on. And of course, diabetes is also clearly becoming an issue. And you also talk about poverty. I mean, poverty is a very, very important aspect part of it. And just before, I would tell you just one quick story before I move on. A couple of years ago, you were doing some work in the rural Ghana, a very, very poor community. And we went there in the morning, sort of doing, people come in, taking blood pressure. And there's one lady who came in, we measured the blood pressure. I mean, the machine could not actually measure it. So it took us a while before we were able to basically measure that. Eventually, we managed to measure it, and systolic was nearly about 234. I mean, if it is in Europe, this is a hypertension crisis. So you are all wondering, are you not on medication? And she said, oh, I am on medication. Can you bring your medication? She brought the medication. I mean, it came back, she was on Adlat. And she's broken those medication into pieces. Her own thinking was that, okay, I'm poor. If I break this medication, it can last me longer. And this is the poverty you are talking about. So it's real. And it's, when you meet it, it's unpleasant. So hypertension, of course, and that is basically what you are saying. And it's really, really particularly problematic among the African region. And it's actually quite striking because if you look at it about 50 years ago, there was a study done in Kenya that basically shows that blood pressure was not actually, that blood pressure is very much correlated with age. But what they found was that it was actually flat. So if one move on about 50 years on, this is what we are currently seeing. And this is the report you produced, one of my PhD students, for the African Union, the report. And that's basically looking at different African countries. Clearly, in some countries, I mean, you are talking about over 40%. And these are huge, huge numbers compared to, say 50 years ago where you used to say that hypertension was not an issue in the continent. And the blood pressure is clearly, many people here are clinicians, so of course I don't have to. But we know that, just about 10 millimeters of mercury increase of blood pressure clearly increases you above, hemorrhagic stroke as well as ischemic stroke. So clearly a very, very strong association in terms of that. You also know that in terms of population attributable risk in African region, hypertension stands out. In other words, if you look at all the risk factors, hypertension contributes to nearly over 50% of all the cardiovascular outcome in the African population in Africa. What about diabetes? This is a report just come out, I think a couple of weeks ago, from International Diabetic Federation. And basically, at the moment, 1 in 11 people actually do have diabetes globally. 1 in 2 are undiagnosed. In other words, there's a lot of people up there with diabetes in the community that actually don't know they do have the condition. And by the time they get to the hospitals, they're already at a advanced stage. And clearly, it's very, very costly as well. And many children are also beginning to develop this. And the projection clearly don't look good either, particularly in the African region. So basically in the African region, the new report just came in. It's actually, this has jumped into 140 in 2040. So clearly, we are witnessing a huge, huge shift in terms of and again, I mentioned that many people are unaware. When you look at it globally, again, you see that in African part, nearly 62%. So in other words, a whole lot of people are walking around with diabetes that they don't even know. And this is the work that has just been published for contributing to a series of books by New York Academy of Medicine. And I just only plotted looking at the overweight and obesity, how they've been changing over the years within the African region. And you see clearly that particularly in the South Africa here. It's a huge, huge chunk of shift from 1990 to up to here, probably 2015. So this clearly also reflects on what we are basically seeing in relation to cardiovascular disease as well. And more importantly, I show this concept because it's actually reflect on it. Because poverty contributes to NCDs and vice versa. Like the example I give here. If this lady who has, basically because of poverty, basically breaking his tablets, that means that this lady will not be able to perform properly in terms of being able to go to farms and help his family. So basically, it continues, you know. So poverty clearly putting people at a higher risk, and as a result of the poverty, also make people very unhealthy. And that you are also seeing what you call the so-called deficient theory of coronary heart disease. I don't know if people are aware of this, but to explain it very simply, basically what we are seeing that if you look back in Europe and in America, back in the 50s, it used to be actually the rich who had a lot of problem with cardiovascular diseases. But as time goes on, and people become aware that actually the lifestyle is driving them, it's the same rich who actually were very quick to adapt a healthy lifestyle. And then the poor became trapped. And that's why in Europe you see that those with the lowest socioeconomic status actually have a higher risk. We are beginning to see that patterns happening because many African countries and low and middle income countries, you also know that it's the rich which actually have a higher rate of cardiovascular diseases. But this trend is also beginning to shift. And so those people who are poor now are beginning to get caught up in the problem. Now, what we are seeing in the low and middle income countries, we also know that the vulnerable populations, such as the migrant populations, are actually also having similar problems. And here, I'm going to touch on the migrant minority population. If you all heard about what is happening in Greece, the African migrants and everything. The issue is when people end up in these countries, what are their health actually? And what can we learn from this? And of course, there is a very famous that, migration isn't just only for the birth. Human being is being on the move actually for generations. And every generation has its own unique migration patterns. And I always say that it is part of us. It's a humanity. No matter what you're going to do, it's going to keep on. You will die and go, but migration will stay. And that's as simple as that. But the way you manage it is, of course, is a different story. Well, when you say migration, basically it refers to any process of moving of a people across international borders or within a country, either permanently or on a temporary basis, depending upon whatever reasons. And you have several key, which is that it can be permanent. Can people settle for the country? They don't want to go anywhere anymore. It can be temporary. People can just move for a couple of months or back. And there are also people who are being forced to move. And before, if you move the clock back, say probably in the last centuries, migration process used to be just only one way, particularly if you all remember the transatlantic. But today, migration is completely different. Everybody is moving everywhere. So basically, migration is actually every country in the world is actually in it. So basically, migration processes have a huge impact on everywhere. And you know that in Europe, this is a new data here. These are the numbers of international migration here in millions. Europe is at the moment the country with the largest migrant population, and these are the figures here. I won't dwell on that. Again, here you see that many countries clearly are shifting, but in terms of numbers, US actually stands out compared to other countries. Within Europe, before I move on into health, I think it would be very nice for us to have an idea how these migrations are actually in terms of distribution. What we know is that just about, in terms of gender, about 50-50. And you know that large chunk of those people are actually at working age population, nearly 80%. And you know that the major countries of migration to Europe actually taking Morocco and others to the European Union. And in terms of numbers, actually I decided to put this arrow here to see the Spain, how Spain is doing, because I'm here in Spain. So basically in terms of the level of that, Spain is actually quite low compared to other European countries. Now, one would then ask, why people move at all? Why people move? This one actually summarizes it all, and I tend to quote this because it says migration is the oldest action against poverty. It selects those who want help. It's good for the country to which they go. It helps break the equilibrium of poverty in the country from which they come. What is the perversity of human soul that causes people to resist such an obvious good? There are several. You have what you call the push factors. And the push factors is basically, at the moment, what you are witnessing in Syria. If there's a war, people will be forced to put their children actually over the seas because they want safety. And that's a typical example of that. And you also have a pull factor where people coming into the country, and this is very typical of students going into the country and then learn. And you know that in general, particularly in the last few years when the migrant moved, they are actually quite healthy. But as time goes on, the condition changes. And what others people used to call it the healthy migrant effect. In other words, if you see the health of the migrant population being better than the local population, purely due to the fact that these people tend to be quite young. But it changes very, very quickly. But the conditions surrounding migration process can actually put people at a higher risk, and that's basically a matter of fact. Increasing separation from families, migration, human, or what we are seeing in Greece is a typical example. And before I move on into the health, probably more worth to look at what you call ethnicity. What is ethnic people? Basically, when it's a group you belong to, or you are perceived to belong to because of your culture, and that includes language, diet, religion, ancestry, and physical features. And it includes country of birth as well as race. So how can you actually take this advantage in terms of migration? How can we actually learn, there are three distinctive ways how migration can be studied. And the first one here is basically comparing the migrants with the host population, which is basically what is actually happening in most cases. In other words, you assess inequality. There are also, you can also compare the same migrant group living in different countries or locations. In this situation, you'll be assessing the role of national context, which I'll be showing you the concept of this soon. Third, you can also compare the migrant with the home country, in other words, the people that did not move. Again, here you'll be studying the real impact of migration. So what is the health status of the migrant population? I mean, this is most of my work is actually concentrated. You know that most of the minority population, particularly from the European perspective, actually have much worse health outcomes compared to the European populations, particularly in terms of cardiovascular diseases. And it also mostly depends upon the minority groups that you are talking about. You also see a huge difference. And the typical example, if you look at coronary heart disease and stroke, you know that this is very, very common among the South Asian population. When I say South Asian population, I mean Indian, Pakistani, Bangladeshi populations. For the African population, for some reason, stroke is very, very problematic, but coronary heart disease is actually quite low. Again, why? Especially given that hypertension has such a huge correlation in relation to that. Again, why is that? Again, this also reflects some of the most risk factors that we know, such as diabetes and hypertension. And some of the examples of the work you've been doing, which I'll be showing you. And this work, I just got it published, I think, it's about 2 years ago, where we actually look at the whole Netherlands in terms of stroke. And I think, actually, what was very, very good, and why we actually, I always say, why we get this to stroke, is due to the fact of it here, which I'll be showing you. So basically, if you combine all the strokes together, what we are seeing is that in most populations, such as Surinamese population, which is comparable the African origin and the South Asian origin in the Netherlands, and then the Antillean, also the African origin, you see clearly that the incidence of stroke is much higher on this population. But then if you look at Morocco, a population from Morocco, they're actually advantageous. Again, why is that? If you then break it into stroke subtypes, then you're beginning to see interest, particularly here, that the Chinese population, we know that is one of the healthiest in many indicators. But then if you look at intracerebral hemorrhage, they actually stands out. So that also means that if you actually want to look at stroke, if you take stroke as the total stroke together, you're going to miss these people if you don't break it down to look at different type of or subtype of strokes. And this is the same thing also applies in women. We also know that socioeconomic status is a very, very important predictor. But as I say to you, the deficient theory of coronary heart disease, for the minority population, is also a tricky, because we were seeing that actually for the minority population was the opposite. So to only come out with a policy to target only the lower socioeconomic people was always difficult, because for the minority population you have to cut across. But we knew that this was going to change. So we test this hypothesis. This also just published in Stroke also. And clearly what you're beginning to demonstrate for the first time is that you see clearly that socioeconomic, clearly if you are poor in all the ethnic groups in Europe at the moment, certainly in the Netherlands, your risk of stroke incidence is higher. So basically this is changing. What about the risk factors you talk about? Again, here you have a big study, one of the biggest studies in the Netherlands called the Helios study. Actually, it's one of the biggest in Europe, looking at multi-ethnic population. And if just myself just led a piece where we look at hypertension. And for this one here, I'm just going to go through here, because probably here will be much more interesting to the clinicians here. And this is the total population. And the hypertension among the Ghanaian migrants in Amsterdam is nearly 62%. I mean, this is huge numbers we are talking about. Compared to, again here, the other African population, which is the African Suriname population, is also near compared to the other group. This is Dutch, and this is the Moroccan population. Again, this is also reflected on the stroke data that I showed earlier. And if you then cut this across different age groups, if you are 50 and above, nearly 80% of the people do have hypertension. So this is actually very, very worrying findings. Before too, I mean, my own work about 10 years ago, we actually were quite worried that the higher prevalence that we see among these people has to do with treatment. But this study clearly shows that actually most of the minority population actually are aware of the condition when they are, and they are more likely to receive treatment. But for some reason, it doesn't translate into control. So what is actually happening here? Is it a compliance, or is what? We don't know. Again, here we need to figure it out why this is the case. And this can go wrong. The same thing also when you talk about ethnic disparities in chronic kidney disease. Clearly, again here, this is also reflect on what you see. So clearly, this is the Dutch white population in Amsterdam, and this is a different minority population. So you see a huge, huge disparities in relation to chronic kidney disease, which you all know is a very, very important risk factor. And even if you adjust for many risk factors, the difference is still clearly over there. And we've just also done a systematic review on diabetes, where one of my PhD students, Kalan, this has just been published by, I think, actually, I've just seen that this morning, just been published. Excuse me, officially. But again, here, what you see is that the risk is nearly up to 4 times higher compared to the European populations. And then when you then break it up to the South Asian population, some nearly 6 times more likely compared to the European population. Again, we see a huge, huge disparities in terms of diabetes. It's not only that. If you also compare the minority population back to your home country, which I'm going to talk about very soon, this is the work we did back in 2009, where I compare obesity and diabetes rate to Ghanaian migrants and their compatriots in their home countries. So this is the same population living in the rural Ghana. This is the population living in the urban, and this is those that's moved to Amsterdam. And that shows the power of the environment and how environment can actually influence your health. This leads to the question, why? I would say that explaining the ethnic inequalities, it's quite hard. It's not that simple. And I will be showing you why that is that. Basically, 2 key areas are being discussed. Some people think that it's all in the environment, and others think it's all on your genes. So it really depends upon which field you belong to. And that has to do with the fact that, there is no work. So everybody can basically argue their case, and you cannot because you don't have a strong data to challenge that. But you know that environmental factors certainly do play a role, especially given the globalization and food, what is happening today. I always show this because there's a lot of change. These days, actually, this was 2004. If you back on 2016, probably this has doubled. It really depends upon how, and this can indeed have an impact on our health. But the fact is, although you know that environmental factors clearly do play a role, when you then adjust for them, you still see differences. And that leads to the question, is it the genetics or the so-called epigenetics? But of course, epigenetics is increasingly becoming very, very important. People that are not into this field, basically this is just interaction between the environment and the genes. And that you know that epigenetic factors can clearly influence your cardiovascular outcome. It can also be, for the migrant population, basically, where you are migrating to or where you are migrating from, in other words. And that has to deal with the opportunities in life in the country of where you end up. Lifestyle-related factors in the country, and basically healthcare-related factors. And I use my own as an example. When I was young, immediately after school, I went to England, where I studied. I would say Scotland, where I studied. And when I was in Scotland, University of Edinburgh, there was no way that I was actually going to sit on a bike. No way, because it was too dangerous. I moved to the Netherlands to do a PhD there, and then almost everybody is cycling. So you actually have no choice. You have to basically take on. So you can see how the environment can actually shape your life. So environmental part and the country part can certainly have a huge impact on that. And you also know about what you call the migration histories. How did people actually migrate? If you have people coming with a higher socioeconomic status, they will do well in the country because the country might need them, compared to people who have never been to school and others. So all these factors can basically play a role in it. And I've just come out with this migration theory. I call it migrant porn effect, What do I mean by this theory? We've just published this idea. Basically, what I'm trying to argue here is that the health status of the local reference population will ultimately determine the relative health standing of the minority populations. And the typical example is that if you live in, say, in Spain, or if you live in, say, Catalonia, whereby the local population is very, very healthy, if you are a migrant, in the end, you're going to be compared with these people. So if these people are very healthy, immediately will have an impact on your own. And I use this as an example. This gentleman here, if he goes here, all of a sudden, he's a big guy, isn't it? But if this gentleman ends up in this part, the situation changes. That is exactly what I mean by this migrant porn effect theory. And if you put it into human beings, if this gentleman go here with the population who are quite, healthy, you all of a sudden either, become. But if this gentleman move to this country where people are basically a little bit more have weight on, all of a sudden he finds himself being healthy. Okay, and this is what I mean by this concept. And this has just been published quite a while. And I think you also have to realize that actually within Europe is not monolithic. It's a huge disparities between European countries. And this is again here, a typical example of, say, in the Netherlands, in terms of obesity, it's just about 10%. If you move to England, we're talking about nearly over 20%. So there's a huge disparities within these countries. And we also myself tested this a couple of years ago, whereby you compare the same population. This is Dutch white and English people, and then the Caribbean population. Clearly you see that, if the Dutch Indian population have a higher risk of diabetes compared to this. And then for women, this is actually clearly so. In other words, where you live do play a role. And the behavior part is actually quite striking. Because here, this is smoking. You know that smoking is a big problem in the Netherlands. So if you are a migrant and you live in the Netherlands, your risk of smoking mimic what you see in the local populations. The same thing with this work that we did, where we look at, that, particularly France is one of the countries where cardiovascular disease advantage is very, very high. And it turns out that if you're a minority person and you live in France, your cardiovascular disease is also better. Again, here, the power of the environment is clearly showing. So with all these difficulties and trying to figure it out what is actually happening and the difficulties, we think that it might be useful to come out with a different approach. In other words, approach whereby you are not only comparing the local population you are, but you also need to extend it to the source population. In other words, the migrant population, to their home country, because that's where you can land. That is also opportunity to be able to simultaneously helping the migrant population as well as in their own home countries. So with this, we developed the RODAM concept. So I have to rush a little bit. So I'll be talking a little bit about the RODAM study now. And this is the study which was funded by European Commission. In 2012, European Commission funded 4 key projects. One is Epi-Migrants, one is a GIFT, Medigenes, and the RODAM, which I lead. So I'll be telling you, and this was a collaborative project across several European countries, as well as Africa. So what is the aim of the study? Basically, you wanted to understand the gene-environmental interactions, other words, and also clearly identify the important risk factors to help us in terms of prevention, and also to provide basis for improving diagnosis and treatment. And the key specific objectives are here because of time, so I need to move forward a little bit. So for the concept, very briefly, basically what our argument is that if you are a migrant, you move to country, you are basically will be able to be influenced by the local circumstances, health systems, socioeconomic status, nutrition, and everything. And this will basically lead to lifestyle that you adapt in the country, and subsequently doing that. You also think that, early life, the so-called biker hypothesis, you know that actually your cardiovascular disease starts from the womb. So if you are born little, you know that your risk of cardiovascular disease is increased. And you know that in poorer countries, low birth weight is an issue. So what did you do, roughly? Basically, what we did within this context is that we started with the Ghanaian population, because I originate from Ghana. People will be asking why Ghana. So that's why I decided to do this, to clarify that. So we look at the population living in the rural and the urban Ghana, and those that actually have moved to London, those that have moved to Berlin, and those that have moved to Amsterdam. And within all these places, we actually decided to sample about 1,250 per site. I think it's a huge undertaking. But I think that we can be quite proud of ourselves, because we managed to achieve quite a tremendous amount of work. These are the numbers, which is you just finished a study now. You are very busy writing up. Different studies is currently being written up. So these are the numbers. And as you could see, Berlin was a little bit on the low side, because for them this was new. And it was therefore the sampling was quite difficult. So in Amsterdam, we increased the numbers to make out for it. So these are basically our team in Ghana, those that actually contributed to collecting this data. They went from villages and everywhere where we collected the data. And then this is London, the group, and this is Berlin, this is Amsterdam. We just have a cake here because we managed to get our numbers, so we decided to celebrate. So that's why this is a PhD student cutting cakes about that. And to do this work, I think one of the important things is also making sure that the standardization is absolutely important. So we ship all the samples basically to one lab to prevent intra-laboratory variability. And then also for the genetic material to Nottingham and also to Berlin. And the protocol has been published, I think about a year ago or so. And we have, again here, the power of what I'm saying about this approach is that if you do this type of idea, you can simultaneously help these countries in the South as well as Europe. And we've just presented this results to the Ministry of Health in Ghana back in September, and already is beginning to be used. I mean, it was all over the media, and now the government is actually taking actions because they were not expecting the results that we actually found. So basically, looking at the migrant and comparing them can actually have the opposite impact simultaneously. So I'm just not going to give you a very quick results of some of these. So this is basically a standardized prevalence of overweight and obesity. So if you look at it, this is men, if a BMI is 25. So if you live in a rural Ghana, this is about 8%. If you are in urban, nearly 40%. If you are in Europe, this is what you see. So this is for that. Men. In women, actually, if you're living in the rural part, you are talking about nearly 40%, which is, these figures is higher than what you see in Europe. And this is in the rural part. And those living in London and others is nearly about 90% of people you sample are either overweight or obese. When you look at obesity, which in other words BMI is 30, again here you see that this is a huge number. Remember the figures I showed you, in the Netherlands the total was just about 10%. So clearly the minority populations are disadvantaged. And in women, over half of the population are obese. The same applies to abdominal obesity. So basically when you model this, you see that in some places, London, nearly 10 times more likely to develop obesity compared to those living in the rural part. We also saw exactly the same patterns when we then look at diabetes. Diabetes rate in the rural Ghana is 3.this%. And these figures are far higher than what you see in Europe again. So clearly, what actually this was a shock to the Ghanaian government was this one. And what is actually also for us as a scientist is that we were expecting a very clear gradient. In other words, you move from the rural, urban, and then Europe. But it seems like the urban Africa today, actually, that protective effect is no more. So basically, what is happening in the urban Africa is similar to what is happening in Europe. And that is a very, very strong message that, this is a problem that needs to be taken care of. And this is why Ghana government is actually doing something, want to do something about this. And again, we look at impaired fasting glucose. You know that many of you are clinicians. Impaired fasting, if you do have that, your chances of developing diabetes is very, very high. But for some reason, people living in the Netherlands appears to have high rate of this. And I saw this also with the previous study that I did. So it seems like something is going on in Amsterdam that we need to figure it out what it is. So one PhD student is looking at this. So probably in the next couple of years, you should be able to understand a little bit. Again, if you plot it against BMI, you see clearly that the higher the BMI, the higher the risk of diabetes. And what is interesting is that with a similar level of BMI, if you live in Europe or urban Ghana, your risk is high with the same BMI. And that probably has to do with the fact that if you live in a rural part, you might do a little more physical activity compared to Europe. So clearly, your risk is increasing. The same thing also applies to hypertension, which again here, this is what you see. If you move up, it's nearly up to 60%. And these figures, I was trying to look for the prevalence of hypertension in Spain. Is anybody know about that? National prevalence? I think it's about 30-something, 35, I don't know about. But if you look at a country like US, we are talking about 30. Canada is about over 25%. So clearly this is a really, really high, a big problem within this group. So clearly the message here is that the migrant population in Europe are clearly affected. You also see that the urban Africa is actually also at par. And therefore, we cannot think that, the migrant population are that. What is happening is that the migrant population, I'm not going to show you some figures, actually better off because they have access. But if you live in an urban part where you don't have access, so this is in the years to come, this is going to have a huge, huge impact on it. So the RODAM. But we know that probably what are you going to do with this? I mean, the WHO have had a very clear vision of how we can actually solve this. And they make it very clear that it has to be a surveillance, it has to be prevention, it has to be a management part of that. And you clearly know that prevention actually works, for cardiovascular disease. And the learning from Finland actually tells us a lot. If you go back into the 1950s, Finland used to be one of the countries with the higher rate of cardiovascular disease anywhere in the world. But they've done well. Now they are actually at par within the European part. So that means that with the appropriate interventions and others, you can actually make a progress. So it certainly can be solved. And you also know that for hypertension, clearly, even if you reduce blood pressure by 2 millimeters of mercury as a population level, you're going to have a huge impact on all the. If you try a little bit to 5%, we are talking about 14% reduction in stroke. So clearly, we can do something about these problems. And of course, the WHO has all this, there are a very interventions that we know to work, you need to test them. You've just done a work in the slums of Nairobi, and clearly you have a clear effect. The paper is just been published, I think, about 2 weeks ago. So I'm not going to go here because of time. But the issue, though, is that many countries do not even have a policy in place. And that's part of the problem. And this was 2009. You see that many countries didn't even have chronic disease policy in place, let alone even tackling the problem. But having said that, there has been some improvement after 2011 WHO UN meeting. So many countries are now beginning to make progress, and that really reflects on this. So basically, many countries are now putting in place many programs to try to address it. But from my own experience, that in some countries they do have the program, but they're sitting on the shelves. So usually because there is no money, or many traditionally the interest is on communicable disease, so it's very difficult to tackle it. And more importantly, actually, it's the politicians who are actually having much of these problems, but it's very difficult for us to convince them. So we need to basically try to shift it. And just before for the last year, WHO came out with a very, very bold statements. And I think personally, I've got a PhD student trying to review this. And basically, some of the statements they make, like first one here, 25% relative reduction in overall mortality from cardiovascular disease within next 7 years. I don't want to be skeptical, but I really, really don't think you're going to, go there unless we really, really convince governments and others. Otherwise, I'm unsure. But of course, the WHO can be right. It might be that you achieve it. But these are very, very bold recommendations. So if you were to achieve this, then that means that we really, really need to change the focus and really make this a very important part. So that's basically this. Those of you that are interested, you've just got this book out. I edited this with Amadi Graf-Takens, and it could touch on many aspect part of the topic you are talking about, both epidemiology, policy, and everything. So those are interested, you can actually order them. So thank you very much for the opportunity to talk to you. Thank you. Yes, exactly. So I think it would be very nice if people have questions based on what I've said, or because I'm here not as a speaker, but also someone who is learning. So if anybody has, tips for me that I can use it to improve my work, or if you have a question for us to discuss, that is also be fine. Yes, please. Yeah.
Yes. Quisiera preguntar si ustedes están contemplando el... no lo tiene él. Sí. Yes. Okay. Yep. Buenos días. Quisiera preguntarle si ustedes están contemplando el hecho de investigar las enfermedades no comunicables desde la población infantil, ya que cuando esta población infantil tiene enfermedad crónica y pasa a adulto, puede incrementar el hecho de tener una población más perjudicada, no solamente en el aspecto de salud, sino en toda su vida. Gracias.
Thanks very much. I think this is a very, very important point when you talk in terms of children. And I think actually that's where you should begin. Because if you could be able to basically try to prevent these children from developing it in the first place, then we can certainly make a lot of progress. And we know that cardiovascular disease also in children, the so-called tracking In other words, if you are a child, you are obese, it can perpetuate till you are older. So I think there is no... Myself, I've done some work on it several years ago, also in some African countries. And we also saw that actually obesity and others is also increasing. We are now hoping one PhD student has done some systematic review on, for instance, looking at overweight and others in children. Again, you're beginning to see that this is also becoming an issue in the African region as well, and particularly also on migrant populations. So I think that we need to do some work. I mean, in Amsterdam, not myself, one of my colleagues, we call it RBCD study. For instance, we started it with from pregnancy, and we are basically following these children till now. I think they are now roughly about 10 years old. So you hope to follow them over time. And the knowledge we are actually learning from this is actually very, very interesting. You've just got a paper which is coming out. We look, for instance, sleep. I think when you talk in terms of sleep, I'm one of the guilty ones. And we know that sleep has a huge impact on your health outcomes, particularly in terms of cardiovascular diseases. So the work we are doing, we see that sleep is very low among the migrant populations, and it's also very much correlated with, say, hypertension and obesity. You've just done it in children, and you're also beginning to see that actually in children also, the sleeping patterns is actually very, very, just like, the older population, actually clearly showing that the social background can actually influence it right from the beginning. So you are now basically trying to already convincing the government to start doing something about it. So clearly I agree with you that, childhood is absolutely crucial and you need to do more about it. Yep.
Thank you very much for this great presentation and for the research you're doing. My point addresses a little bit your somehow sensitivity to policy issues or the policy implications of knowledge, and your double link both with developed countries, for example, the Netherlands, and developing countries like Ghana, as you described. So my question is, how do you foresee the orientation in these different contexts regarding facing some of the problems that you have described, and specifically whether the orientation is towards screening these groups of so somehow promoting secondary prevention initiatives and therefore involving largely health systems, or whether the emphasis is placed more on primary prevention and then more towards community orientation. And for the case of Ghana, what is a little bit the orientation that, based on the evidence that you've presented, the trends are, taking into account there are many other priorities on the table at the same time? Thank you.
This is, again, a great point. How do you translate these findings to actually to make a difference on the ground? And I think it's a very, very, a big challenge, but we are making progress. And the progress I will make is that already the findings from this, certainly in Amsterdam, we are now basically translating this. And we are very much engaging not only the Ghanaian population, but the African population as a whole. We now have what you call a program whereby we are training from every organization. One of the things about the African communities is that they are very well organized when they move. So that makes it very, very easy for in terms of prevention. So basically we've set up programs whereby we are training for each organization, basically training one person so that they become a gatekeeper within that communities. And we are now also just got one postdoc has just got a grant, which we are starting to call it the Family Project. And the idea is that you want to train the family units. Because if you train the family units, and that can also come back to the point of children. So basically you can simultaneously address the entire family as a whole. So you're going to basically start in this project. and then hope that you can make a difference to that. Of course, London and others where you do the studies are also coming out with some initiatives now. But to Ghana, certainly, this is having a very huge impact. And the Ministry of Health clearly wants to do something about it. We've been in touch with the WHO Ghana. They also want to translate part of it. But the problem, as you clearly hit the nail on the head, is the resources, competition of resources. How do you come out with a model whereby you can simultaneously address the priorities as well as, But I think that there has to be a priority putting on NCDs, because basically what you are seeing, if you look at the Ghana health indicators, now the basically chronic disease sitting about 5th place. So you cannot turn a blind eye as this problem doesn't exist. Because if you don't, then you're going to have a huge burden on the system. So people are seriously taking it seriously. But our hope is that, you continue to support them. What I want to do in the future is to basically this work turn it into a prospective study so that you can come out with the clear predictors to help them to develop this further. So, I hope that the government, of course, the politicians, they are just like weather. They change very, very quickly. When they see these figures, they are very, very scared. But as soon as you go, then... but we are engaging with them, and I think that you should be able to convince them somewhat. Thank you.
I will try to ask you in English, but I don't know if you will understand me.
I can understand you perfectly well.
Yes, thank you. So I want to ask you if you did some study about the disability, the physical disability, the speak disability after a stroke, a comparative study between African people living in Africa, like Ghana, and migrant people and European people.
The stroke part, we have not basically done a comparative analysis. The stroke part was done purely in Europe. But I have written a piece on, I think a couple of years ago, I did a special issue for Ghana Medical Journal to try to basically bring attention to this problem. And I wrote a piece on looking at stroke. And basically, we basically extracted the data from the clinical to show what is happening. And I think that studies actually have had a lot of influence in the country. Because what we found was that, particularly in terms of handling of hypertension, people coming in with the stroke and others, people on average hypertension among those stroke that were admitted that, after a week was nearly over 200. So that means that the system was not clearly, suited to address some of these problems. So you've basically highlighted some of these problems that actually within this level so that they can do something about it. You also have collaborating with the university whereby we are now also interviewing the stroke patients. Because I think one of the interesting things, and again here I will put a one personal touch to that. We did a work again in one Ghana, in one part. When you are doing these studies, you come across many things. There was one person, was a stroke patient. And you wake up in the morning. When you go to that, the person was basically stroke. If you are in Africa in stroke, if you don't, everything is organized by the family. They put the person on there, sitting here. You went for our business for the whole day. We came back, the person was still sitting in that place for the whole day. So clearly, the issue then becomes, what actually happens to these stroke people after they've left the hospitals? So we are basically trying to find answers to those. But I agree with you that probably in future, we need to basically also to do that. And that's also one of my, if you're able to turn this into a prospective study, you should be able to study these as well.
Sisplau, última pregunta aquí i acabem. Sisplau, sí. perquè anem molt justos de temps. Gràcies.
Thank you, Charles. Actually, I had a couple of brief questions. At the beginning of your presentation, you touched upon briefly on the double burden, and that is being talked about even in some cases triple burden, particularly in sub-Saharan Africa. So, based on your knowledge on the epidemiology of Africa, do you think this is a real aspect for concern, or is more alarm than data supported? That's one point. And the second is that for infectious diseases, we have seen the international community mobilizing for good and with great results since the creation, for instance, of Gavi or the Global Fund. So for non-communicable diseases, we have had some initiative from the WHO and then commissions by the Lancet and others. But do you think that tackling non-communicable diseases will be basically a responsibility of health systems of emerging countries? Or what is the role of the international community in addressing them?
Yeah, again, this is a very great point that you've raised. For the first point is whether it is alarm or whether it's real. I think that's a very interesting and very well thought question. From my perspective, I think that I wouldn't say it is alarm. I think probably what I would say is that it has been a problem which has been sitting there, but you all kept basically you chuck it under the carpet. You didn't want to see the problem. And now people beginning to realize that it's about time that we need to address the problem. And so basically, if you like, it's sort of reality coming to the fore. So I think that's how I see it. And I think it does also reflect on the ground. If you go to many African countries today, and if you look at, every hospital, if you look at the top 10, you see that almost every country, NCD is really, really figuring out. So that clearly shows that this is real. And in terms of the global community response, I think that, of course, if you look at, in terms of many African countries, clearly, it is very clear that, if you look at on the ground, many of these countries, problems are, in most cases, solved by their own communities. International contribution, of course, is very, very important, but a large chunk of the contribution comes from these countries. But I think what the international community can do is to basically use the platform like we had with the UN, whereby we are committing the whole countries, the leaders, to take action. And I think that's what they can do best. And the 2011 UN meeting, whereby they commit many countries to do this, actually have had a huge impact. Many people are now beginning to take it very, very seriously. So for that is very, very important. I think you can also learn a lot from what is happening in the high-income countries because they've already gone through this. So how do we translate those knowledge that you've already learned here to these countries? In other words, those interventions that we know that these interventions work, how do you basically translate those? Interventions are very much driven by context. So you cannot basically cut and paste those interventions into these countries. You need to test them and see whether that work in those contexts, taking into account the cultural aspect part of that country. And I think for that, the international community can be of help. And the typical example is the work that we did in the slums of Nairobi, whereby we decided to build clinics and provide the necessary instrument to see whether that can have an effect on the management of hypertension and diabetes. And clearly, it did work, but we had to adapt it to the community's wish, because sometimes, these people, many people have their own priorities. If I'm thinking about food on the table, what should I worry about? Hypertension or diabetes can wait. So you need to basically figure it out and think with these people and see how best you can basically bring it into their daily life to make it meaningful. And I think again here, experiences like, institute like, IS Global, which have a lot of experiences also in the communicable diseases part, can be, what we've learned from that can be translated into NCDs as well, I think.
So, Dr. Agyemang, this is the last question.
Okay.
We really enjoyed your conference, and we hope it won't be the last time.
Okay, thank you.
And now we have time, just 15 minutes for a break, and